So we have some funding for our work, but really the most important thing is just the gratitude I have for the many teams I get to work with. And I heard Jane Clardy's voice in the room. She was already on the slide. And, we end up when we work in these collaborative environments having a lot of shared ideas. So she may hear some of her own ideas kind of echoed throughout this talk. And then I'm going to take some time to really highlight some of the work that our trainees who are now not necessarily trainees anymore, but moving along in their careers and share a few of their work stories. Maybe there's some trainees in the audience who can relate to kind of starting a brand new project with kind of a middle-aged professor or associate or assistant professor to move their own kind of research interests forward. So this is really a geographically inspired story. So this is a modern day picture of where I lived in the late 90s, early 2000s when I was a medical student at Temple. So this was in Northern Liberties. And I can tell you that it was a lot easier to find a parking space in Northern Liberties back then. And I lived in this kind of bay window apartment building you can see here. And actually, right next door used to be a funeral home. So most of the time, you could get a good parking space unless there was a funeral. But Northern Liberties has undergone a lot of changes. But what I did notice in this most modern picture is that there's still very little shade covering in my old neighborhood. And I used to bike commute to Temple. Maybe my parents didn't know that. But I would bike to Temple and there were very few kind of shaded opportunities. I remember, especially in the summer, how hot it was to bike from 4th and Fairmount up to North Philadelphia for school. And I think this kind of planted a seed, no pun intended, on some of the kind of structural interventions that we're starting to really think about in the last 10 to 15 years to improve health in Philadelphia. And I would drive by or bike by homes that had also some structural challenges on my way to Temple. And then I moved to the Art Museum area, Fairmount, for when I started being a resident at CHOP in the early 2000s. And you can notice here, this is now a modern day picture of my block, which has also improved since I lived there. But you can see a lot more kind of shade and tree covering. And my bike commute to CHOP wasn't quite as hot as my bike commute to Temple. And so, as I mentioned, I am a neonatologist. So after that residency, I ended up going to do a fellowship in neonatology. And I wanted to just share what that means is that like I think I heard Becky in the room as well, pediatric subspecialist. So we get additional training in how to care for sick neonates. So babies that are in the neonatal intensive care unit, which we'll refer to as the NICU. Not all, but many of these patients or babies were born preterm, so before 37 weeks or even earlier. And what we notice as neonatologists, and a lot of public health researchers have also noticed this, is that families with multiple stressors are more likely to have preterm infants and end up in our NICUs. And then the NICU itself can be an additional stressor. But we also know that women and birthing people with kind of pre-existing illnesses or comorbidities are more likely to have a preterm baby. And we know that poverty, disadvantage, and other forms of disadvantage put people at higher risk of having a sick baby. And so one of the ways that we measure disadvantage is by self-identified race and ethnicity, mainly because there's been so much discrimination and racism over generations and current day that lead to multiple environmental exposures. And I broadly define the environment. Whether it's the, organophosphates you just heard about, or whether it's, exposure to social stressors or air pollution, it doesn't really matter. There are very few exposures that are more common in more privileged groups, but a lot of adverse environmental exposures are disproportionately concentrated in areas of disadvantage, and areas of disadvantage also are more highly populated by folks who identify with races and ethnicities that have been minoritized for a very long time. And so right now I'm going to show you, these are data about maternal mortality. And you can see that by race and ethnicity, there are a lot higher rates in groups that identify as American Indian or Alaskan Native or identify as Black compared to other groups. And then we see kind of similar patterns when it comes to preterm birth. And so what this means to me is that sicker moms are also the same folks who are likely to have sick babies. And this just means that families generally are sick. And so that's going to happen throughout the life course. And when I talk about race, it can get a little dicey, especially right now. I mean, I think a lot of this is really emotionally charged and politically charged, but it's really important that we just kind of set the stage that I'm not talking about race as some sort of genetic code that is within our bodies that is leading to all of these different outcomes. I'm talking about this really as a social construct. And when I say that, a lot of us hear that and we don't really know what to do with it. But what I mean when it comes to public health and health disparities, that we're talking about health generally across a continuum, right? So all of our health is a combination of our genetic code and all of our broadly defined environmental influences and personal behaviors, right? And so we do observe racial differences in some genetic diseases. And so I'm not discounting that, but I think this is where it gets very confusing, especially in medical school. You see a pattern like something like sickle cell disease or cystic fibrosis or Gaucher's disease that might be really common in one group. And we know that's because of one single gene mutation. And then we assume that the health differences we see, like in the NICU, might also be genetic. And I'm going to explain to you why that's not likely the case at the population level. As we move across this continuum, we move into things like breast cancer or multiple myeloma. These are diseases that are more common in certain groups. And so every time I go to the doctor, they always want to know, are you Ashkenazi Jewish? And the answer is half. And then they're really worried about my breast cancer risk, right? And so there are genetic predispositions to these types of conditions. But also, as I mentioned, and some of you have heard me say this before, my drinking habit in college also might contribute to my breast cancer risk. And so it gets very dicey, right? And so there's not just one form of breast cancer, and there's not just one gene that is going to cause everybody's breast cancer, right? And so we get into this heterogeneous multifactorial condition that is breast cancer. And then we move even into more heterogeneous and multifactorial disorders like cardiovascular disease, stroke, asthma, type 2 diabetes, where there isn't just like one gene that's going to explain the differences in population levels of these diseases. And then we move all the way over where there's no genetic reason for these things, right? So if you're dying more often of gun violence in West Philadelphia, if you're a Black man, that is entirely social, right? Or if you're a, rich white guy and you're falling in a tiny aircraft, that's because more rich white guys are going to be flying around in their planes, right? And so you end up with this entirety of that racial disparity and that outcome being socially driven. And where I put preterm birth is way over here because of what Dr. Kelly mentioned earlier. This is a very heterogeneous multifactorial disorder. So when Becky and I get called to see a potential parent of a preterm baby and to let them know what the NICU is going to be like for a baby who was born at 29 weeks, that might be because she's in labor. And again, as we know, we don't really understand that, but whether it's labor or maybe the water has broken or the membranes are ruptured, or maybe it's that she was feeling fine, went to a prenatal care visit and was found to have hypertension and protein in the urine, and now it's safer to get the baby out than to keep the baby in. Maybe she needs chemotherapy for a deadly cancer, and so the baby has to come out before the chemo gets started, right? These are very different reasons, but we all lump that into one thing we call preterm birth. But what I would say is that because of that heterogeneous multifactorial difference, and we see racial disparities through all of these preterm phenotypes, I would say that this is much more on the environmental end of the reasoning for the disparity. And it's not just because I say so, right? There are data. This was a groundbreaking article in 1997 by Richard David and Jimmy Collins in Chicago, showing that women who gave birth in Illinois, and you can see the birth weights on the x-axis and the proportion of all births on the y-axis, and you can see nearly overlapping birth weight distributions among infants born to white mothers and infants born to Black individuals who had been born in Africa but gave birth here in Illinois. And then you can see this substantial shift to the left. So smaller babies born to Black women who themselves have been born in Illinois. And so what that means is that being Black in this case, Illinois, but in America for at least a generation was driving lower birth weights. And we know genes don't change that quickly. So it's not about some sort of genetic Blackness that's causing these lower birth weights, but really the multi-generational experience of being Black in America. And this has been borne out in other studies that have looked at preterm birth and adjusted for confounding variables. And it's just very robust that in general, foreign-born Black women have better birth outcomes and perinatal health outcomes than US-born Black women. So again, there are environmental reasons for this. And so our research group really thinks about the population level exposures that may lead to these population level differences and what we might be able to go ahead and do about that. And so we think about this as an expanded framework for both preterm birth, but also other perinatal outcomes, and thinking about this macro environment, which is all about the air we breathe, the water we drink, the metals that are in our pipes, the food wrappings, all the things that are going to be different and patterned by what your life is like, right? As well as all the social exposures. And I think Jane would argue, and she's in that room, that, it's really the combination of these things. And sometimes it's more one and sometimes it's more the other. But ultimately, our bodies can only handle so much. And so when we overwhelm those resilience mechanisms, we are going to end up with a higher risk of adverse outcomes. Okay, so what I'm going to make the argument for, and I think I'm probably preaching to the choir, but neighborhoods matter for health, and I didn't make that up. Really, one of the mothers of this field is Ana Diaz-Rue, who's right down the street at Drexel, served as the dean for many years, but she really did some incredible work linking neighborhoods to cardiovascular health, which is very related to perinatal health, as we'll learn. But she really talks about this residential segregation and just the differences in risks and opportunities that present when you have residential segregation, whether it's economic or racial or any otherwise. And she did this really cool study looking at coronary heart disease, another groundbreaking study that was also published in the New England Journal. And she had a data set where she could adjust for all the really fancy variables, including cholesterol and individual level income, which is almost never in our population data sets. And she showed that living in a disadvantaged neighborhood was associated with higher odds of coronary heart disease for both white and Black individuals. And this was really kind of a frame shift, right? It wasn't just, you know, all of your individual variables that are going to determine your health, but also where you live. And so it's important to think about our environmental privileges. I showed you about my kind of early 20s and 30s moving around Philadelphia, and now I'm a boring 50-year-old living in the suburbs. But I have a lot of environmental privilege, and my children do too, right? So this is a Google Map view of where we live, and this is what our street looks like, and it's very green, and there are lots of trees, and we may maybe have access to air conditioning, all of that. And then on my commute to CHOP and to Penn, I drive through other neighborhoods that have benefits, right? There might be more social cohesion perhaps on this street than mine, since I only talk to one of my neighbors and not the other one, right? You never know. But in general, you can see for sure that there are fewer trees. There's the infrastructure of these homes might be very different. There's certainly less shade. And you're also going to be exposed to any environmental exposures that kind of can seep through walls and through porous boundaries. And so what are these? I mentioned a few of them, but there are differences when it comes to zoning and what's allowed to be put in a certain neighborhood. And so what you might be breathing in, there's going to be difference in the lead and the other metals that are going to be leaching out of your pipes, depending on, what your water source is. And then even what kind of food you can grab kind of quickly in your neighborhood, if it's wrapped in some of these endocrine disrupting chemical laden kind of wrappings, then you're going to end up with a potential risk to your health. And so that might vary by where you live. And then I've alluded to kind of the green space and the shading and the differences in temperature. And there are many differences in the social exposures too. So this is just a graph showing kind of economic growth in the suburbs of Philadelphia compared to within Philadelphia. So I'm going to take a moment because, as horrible maternal deaths are, they're not as common as we may think based on what we see in the media at very, very low rates, and just, about 1,000 a year in the whole country. But there are a lot of people who get very sick around the time of pregnancy. And there's a particular measurement that the CDC uses called severe maternal morbidity. And this is the kind of the exhaustive list of all of the diseases or complications, health complications that can happen at the time of the delivery encounter, the birth encounter in the hospital, as well as some of the procedures to help people stay alive. But what I'd like to point out is that one of the most common causes of severe maternal morbidity are all these cardiac conditions. Okay, so heart attack, which is an acute MI, cardiac arrest, and arrhythmia, heart failure, pulmonary edema, cerebral vascular disease, so stroke, right? And so when we think about this is one of the most common reasons, especially for postpartum severe maternal morbidity. And when folks have looked at whether where we live matters for severe maternal morbidity, the answer is yes. This is some work from the Commonwealth Fund that shows that living in the Northeast is associated with severe maternal morbidity, which I would argue that's where we are. I don't think they would count us as the South. And then also folks who live in communities that are in the poorest quartiles. This would be income levels that are very low is also associated with severe maternal morbidity. And this takes us to our first project that we did in Philadelphia. So that's kind of national data. Actually, this I think was New York City data. But here we're going to look here right in our own city. And so we've collaborated with Alan Just, who is an environmental epidemiologist up at Brown. And he now even has a fancier model than this, but we have overlaid lots of environmental exposures, including thinking about where residential segregation has happened throughout Philadelphia, and then how these different neighborhoods have been treated over time. So many of you know that there have been different kind of government-backed policies that have either kind of encouraged investment or discouraged investment throughout neighborhoods in Philadelphia. And I just like to point out that you're all if you're in the room, you're sitting over here on the leftmost side star. The other one is Pennsylvania Hospital. So when we overlay exposures in formerly redlined or disadvantaged neighborhoods where governments really didn't want to back mortgages, you can see that to this day, or this is actually 2015 air pollution data, but you can see higher levels of air pollution in neighborhoods that were formerly redlined. And if you look at many different environmental exposures, you see that there's this long trend of adverse environmental exposures in neighborhoods that have been formerly redlined. And so we think about kind of that kind of talks about what was happening back in the day. But when we think about current day residential segregation, there are many ways to measure this, and some would even argue that this is not a segregation measure, but I still think it's very helpful to think about this measure, which is called the Index of the Concentrations at the Extremes, or ICE. And it's a way to quantify whether there are lots of people that are advantaged or a lot of people that are disadvantaged within a particular geographic unit. So in the slide I'm about to show you, we're going to be talking about this at the census tract level. So some of you have done a lot of GIS and so geographic information systems analyses. Others have done very little, and that's fine. But there are ways in which we can kind of nest, and we think about these as kind of like Russian nesting dolls. So you have your census block, and then you have your block group, which is a little bigger, and then your census tract, and then census tracts are within counties, okay? And zip codes are kind of separate, but can be overlaid and dealt with using math. But you know, in terms of the census, this is the way that we have done this analysis is to look at census tracts, which are groups of census block groups, and whether there are a lot of people who are disadvantaged. So that if everybody in that census tract were disadvantaged, then the value at that census tract would be -1. And if everybody was very privileged, it would be +1. So if you're talking about, in this case, when we think about income, then it would be everybody is high income, you would have this value of 1, and if everyone is low income, or there's no, or everyone is below the federal poverty line, then you might be at a -1. In this case, I'm going to be showing you both income and race when it comes to advantage and disadvantage. So we are not the people who came up with ICE. Lots of other people have worked with it, and probably most famously in public health is Nancy Krieger up at Harvard. And what she was able to show is that these ICE ratios seem to, or the ICE indices seem to be more associated with adverse outcomes, specifically infant mortality in this graph, compared to just looking at poverty alone. So it's really just that concentration of advantage or disadvantage. And here she's comparing that lowest versus the highest quintile of ICE. So again, most disadvantaged compared to most advantage. And you can see these high rate ratios, whether you're looking at income, you're looking at race, so a higher proportion of Black individuals living in a census tract, and then here looking at a combination of both income and race. And this is much more strongly associated than if you're just comparing the highest and lowest quintiles of poverty. So what we did is what I would call a hospital systems analysis and a data mosaic, where we used all births from both HUP and PNC, so Philadelphia births, but just within Penn Medicine, and we have everybody geocoded, and we have a lot of exposures and outcomes ascertained. And we worked with a PhD student who was doing her MPH at the time, Katie Mari, who recently finished her PhD. And she asked the question, is this ICE measure, so this dissimilarity or kind of concentration of the extremes, is that associated with severe maternal morbidity in our study? And at first she found some surprising results where we didn't really see it, but then we realized that was because we were getting these sick people coming in from the suburbs. And when we restrict to Philadelphia, we do see the association you would expect. So here you're seeing, as we move to the right, you're seeing more advantage. So a higher proportion of white people, way over here on the right on the top graph, a higher proportion of people of high incomes or lower proportions of poverty on the right side, and then a combination of those two values. And you can see that on the left side of each of these graphs, you see the highest rates of severe maternal morbidity. So again, where you live in Philadelphia is going to matter when it comes to severe maternal morbidity. And then we had another student, Nancy Yang, who was an undergrad at Penn, who then worked with us for a year and is now at UCSF doing her medical school training. She looked at segregation in a different way, kind of using the patients within the Penn medicine system. And she said, okay, let's look at the proportion of, among the patients that we have in our data set. Each of these kind of bars in this histogram is a set of census tracts. So on the left-hand side, or census block groups, so you can see that on the left-hand side, most left-hand side, there are about 60 block groups where no Black patients live there, only patients that were white identified. In this case, this was Black and white folks only restricted. And you can see that there are 60 census block groups where only white people lived who gave birth at Penn Medicine. And then you can see on the next set, there's about 75, an additional 75 where maybe just 5% of the patients in the data set were identifying as Black. Whereas you can see way over on the right-hand side, there are other census block groups where almost everybody was identifying as Black, and then very few census block groups in the middle here. I keep saying tracks, but block groups in the middle here, where there's kind of an equal proportion of Black and white individuals, meaning that Philadelphia, nobody's gonna be surprised at this, remains a highly, highly segregated city. And so what Nancy did was she said, okay, let's look, this doesn't look like Philadelphia, and you're right if it doesn't, because we have cut out areas of the city where there were, fewer than 100 births within a census tract over a period of time. But if you kind of look at that center part, that big white blob in the middle, because I don't think you can see my my arrow, but that is Fairmount Park. And then you can see, Schuylkill River would be running right vertically in the middle of this. And on the right-hand side, you would have the Delaware River. So you can see we have really good representation in West Philadelphia and South Philadelphia, and a little bit in North Philadelphia. And what you can see is that the preterm birth risk, and she used some fancy Bayesian analyses in order to smooth and borrow information across census block groups. But you can see this higher preterm birth risk in West Philadelphia in our Penn Medicine birth cohort. And then she broke this up because we know that preterm birth is heterogeneous and multifactorial. She looked at all preterm birth, and then spontaneous preterm birth, and then medically indicated preterm birth. And here she's looking at the racial disparity. So this is the Black-white disparity. And what I want to point out is that in almost every block group, there's a disparity, right? The lightest block groups might be almost, you would need a risk ratio of 1 to have, or less, to have no racial disparity or Black disadvantage. But you can see in all the other census block groups, there is a measurable racial disparity, but that racial disparity is much wider in the rightmost graph and their map. And that is the cardiovascular kind of complications that lead to preeclampsia or poor fetal growth and placental function, or some other medical condition that's leading to that preterm birth. And so while there is for sure a disparity in all preterm birth, in Philadelphia, in Penn Medicine at least, most of that is driven by, or the widest part of that is driven by medically indicated preterm birth. So this brings us to what can we possibly do about this, especially in neighborhoods. And my colleague Gina South, and many of you know her, she and Charlie Brandis have really been pioneers when thinking about greening interventions and structural interventions across Philadelphia. And the Pennsylvania Horticultural Society has been doing this for a very long time. But what they did, and Charlie really led this effort, was they said, okay, to the PHS, the Pennsylvania Horticultural Society, can you just pause for a second? And can we randomize the groups of lots, vacant lots that you're going to green across the city? And then can we measure health outcomes of the people who live nearby? And they've shown in multiple studies now that you can decrease violent crime by doing this. You can improve the mental health of the folks who live nearby. And then Gina, kind of in the pre Fitbit era, put on a different type of tracker and saw people walking by these, she could see when people were walking by green spaces, and she could see that folks' heart rates went down as they walked by green spaces. Whether that is a calming effect or a cooling effect, I think there's a lot that we don't know, but certainly she was able to kind of empirically show that there are physiologic differences as you walk by green spaces. And then we worked with another student who's now attending out at UCLA in internal medicine, Max Jordan, and he was able to show using a birth cohort run by Dr. Elovitz, who's left Penn a few years ago, that the amount of tree canopy coverage that you are living near may be associated with your risk of hypertensive disorders of pregnancy. So this is getting back to that, one of the main indicators for medically indicated preterm birth. So compared to folks who had at least 30% of tree canopy, all the other lower amounts of tree canopy were all associated with higher odds of hypertensive disorders of pregnancy within a 100-meter buffer. And this is adjusted for neighborhood deprivation index. So this is not just a socioeconomic position of the neighborhood, as well as individual level insurance status as well was in the model. So when we think about this looks a lot like what you saw Dr. Kelly present earlier. We think about this racism or discrimination or disadvantage leading to income inequality, residential segregation, educational attainment differences, all of which can either directly or indirectly lead to psychosocial stress, as well as toxic environmental stressors, physical toxic environmental stressors, chemical stressors, and that the combination of really both of those factors really lead to the disparities we see in birth outcomes as well as maternal outcomes. And what we didn't have in this model originally was really around the fact that there are also fewer benefits and fewer buffers in certain neighborhoods across Philadelphia and other cities across the country.